Dave Harshfield, dictating. This is the International Chiropractors Association Lecture 10, pertaining to arthritis and ligaments. The arthritis is closely associated with ligament insufficiency, and we'll talk how that's connected. We'll talk about selenium, and then we'll also talk about spinal cord injury resulting in, or metabolic issues and whatnot that result in paralysis and paresis. So on with arthritis. Let's talk about the study of the bones and kinematics in the cervical spine. One of the interesting things, I think, is that the orientation or trophism of the facets is extremely important throughout the spinal axis. There's a transition. This is the superior facet of C3, and here's the inferior facet of C2. So when we're imaging these studies, here's a CT, cross-section CT to the cervical spine. The more superior vertebral body is going to be the one along the posterior part of this image. So here's the lowermost facet of C5, and here's the uppermost facet of C6. And if you think about weight bearing, this posterior aspect of this vertebral body is going to be pushing forward. Now let's just take a look at where this slice was obtained. Here's C5 right here, and all the way to C5 is going to be pushing down on that superior articular surface of C6. So that when you slice from front to back, when you look at the front, you see the vertebral body, the disc, and then we look to the side, you see the lower facet of the upper vertebra. In other words, the superior facet of the lower vertebra, C6, corresponds to that little tip right there. See how that's anterior? Then you continue to slice more posterior, you have the lower facet of C5, which is this structure here. Now also notice the angulation, the orientation here of the facets. Superiorly, notice how the C3-4 and C4-5, the superior facets, tend to be aimed more posterior medial in the upper spine. Then as we get about C4-5, C5-6, they start to orient their alignment posterior lateral. And then they get to be almost coronal in the cervical thoracic area. And then there's a big change, by the way, from the almost sagittal orientation in the thoracic spine of the facets. And then as there's a resumption of angulation or turning of the orientation of the facets in the lumbar spine, there's a transition between the T12 and L1. And as we've discussed, a lot of the instability and difficulties in the spine is at the junctions. Not so much CO, C1 as the occipital condyle here and superior articular surface of C1, but basically at C1-2, the most mobile joint in the body. And C7-T1 is a big transition between non and rib-bearing vertebra. And then T12 and L1 is a transition between rib-bearing and non-rib-bearing. And then L5-S1 is where it's a transition between mobile L5 or mobile 5 lumbar segments with the fused 5 sacral segments. Now let's take a look at the most important concept. Remember, we talked about ligament insufficiency, instability, and whatnot. Ligament. Arthritis is, there's a known cause of arthritis, and it's ligament insufficiency, and it can also be ligament tightness. We'll talk about selenium deficiency creates tight, noisy ligaments. If you have a noisy joint, it's probably selenium deficiency. We learned that from our pig farmers in Arkansas. As the pigs get older, their hips start hurting, and they give them selenium because it's not in the soil. This is a big problem in the northeastern part of the country around Maine. Natalia Bragg is our resident expert in nutraceuticals, and she told us about the selenium insufficiency. We'll talk about that in the next segment. S down here in our acronym is selenium. But here are the capsules on the outside of the facet joints, and if you peel the capsules back, here's the orientation that we just saw on the last slide. Now, one thing I might comment on, if we look, notice how the C2 sits almost perfectly on the barrel of the C3 lateral mass and so forth. When you start getting to C5, see how this begins to elongate. There's actually a pars interarticularis. Notice how these upper facets don't really have a pars interarticularis. They're pretty much a block vertebra. They start to elongate here. Now they're elongating. Now look at this relationship and look at C7. There's actually a part between the articular surfaces, or so-called pars interarticularis. You see how the development of the vertebral bodies occur. But with these upper cervical, there's not really a pars, so to speak. Now let's look at a posterior view. Here's the spinal cord here. Here's the spinous process, probably about C5, 6, and here's the prominent one of C7. And what we're depicting here is the exiting nerve roots below these levels. Remember, we talked about the exiting nerve root. Here's, if this is C6, the C6 nerve root is exiting right here between C5 and 6. And its dorsal root ganglion provides a medial bundle branch, which innervates the facet. And it's the favorite target for people who want to kill it. Radiofrequency ablation and injecting steroids and other sorts of destructive behavior. All that does is temporarily kill the nerve, which means now your spine has no proprioception and sensory input, and it grows back. So in about 4 to 6 weeks, the pain's back, and all this, the capsular tissues, by the way, the capsule is what's burned and hit with the steroids. So this turns to mush. So your ligament instability is exacerbated by this short-term thinking of RF ablation, radiofrequency ablation, or melting these nerves in adjacent structures, or injecting steroids in there. Now, if we look from a direct posterior approach here, here's the facet joint here, here's our little medial bundle branch, and here's an arthritic joint. Now this whole concept, remember this acronym, we're down to A now, arthritis, and we're going to talk about how that happens. We know it's capsular insufficiency, and it can be from trauma or just wear and tear. And then when you look at it on a CT axis like this, you'll now see the inflamed arthritic facet on the right, patient's right, and then the more normal facet on the patient's left. And here's a central canal. This is in the lumbar area, by the way, the cauda equina. But again, here's the medial bundle branch. Now, let's get our minds around this. Is kind of a little busy picture here, but this is important. If you look at the facet, here's the lowermost articular facet of, let's just say, C5, and here's the superior facet of C6. If we go to this blow-up picture, here's the superior facet right here. Look at the hyaline cartilage, all right? And between those two bones, the facet, subchondral bone, is this hyaline cartilage. What keeps the facets aligned and allowed to be smoothly sliding and to rotate and whatnot is this fibrous joint capsule, the ligaments. So here's the outer ligament anteriorly, and then here's the outer ligament posteriorly, but it goes all the way around the circumference. Remember the picture here. It encircles the facet, this collagen. Now, if we look inside, much like the knee has a meniscus, this is called a meniscoid. It's a soft tissue spacer that contiguous with the joint capsule, and it's attached both to the bone and to the ligament, but it provides a soft tissue cushioning on either side of the facet joint, and this is highly innervated, so that with an arthritic facet, there's a lot of nerves in here, and they can either be inflamed or compressed, and these are big-time pain generators here. Now, let's talk about the C1-2 relationship. It's so unique. Remember, it's a two-football relationship. You got biconvex opposing surfaces. You got the lower articular surface of C1, and you got the superior articular surface of C2. This joint is set up exactly the same way as we saw that picture. So here's the atlas, and there's the meniscoid. See how it looks like here's a magnified view. Here's the meniscoid acting like a meniscus, but it's not a fibrocartilage structure. It's more fatty. It contains a lot of nerve fibers. So between the atlas and axis, you have this meniscoid and this collateral ligament complex. Now, with head rotation, these two footballs have an interesting relationship. And I've got some diagrams in a minute we'll talk about. Here's an arthritic rightward C1-2 and a more normal, but still partially arthritic leftward C1-2. This is a patient left over here. Notice how the occipital condyles here, C0, superior surface of C1, and then here's the inferior articular surface of C1. The odontoids in between. And you actually have bone spur and calcification of the transverse band of the cruciform ligament from this arthritic instability. You can kind of tell the right atlantodental interval would probably be wider if it wasn't ossified. Now the orientation here is very stable. Notice the angulation here of the superior and inferior articular surfaces of the lateral masses of C1. Creates a nice wedge-like relationship. All right, now this is just to remind us that this collateral relationship of the collateral ligament and the underlying meniscus and bone is not in parallel. These structures are in series. And by that I mean, let's take the elbow as an example. Here's the common extensor tendon, for instance, landing on the lateral humeral epicondyle. But even though they're shown in this diagram as discrete structures, here's the tendon of the common extensor tendon. Here's the radiocollateral ligament, then the underlying synovial capsule. They are in fact not found this way except in cadavers. What we do find is that it is in a structure in parallel, it coalesces. And this is the biologic tensile integrity that we talk about. One other thing, the integumentary system consists of the skin and accessory structures, hair, nails, and glands, and the fascia. But in the region of the cervical spine, innervation of this fascia is 6 times greater in the fascia than to the muscle spindles. So think about that. Muscle spindles are primarily in the areas of force transmission. And so there are a lot of small muscles around the craniocervical junction. Now, nerve conduction is about 50 meters per second, but mechanical force travels 1,500, almost 3 times as fast, 1,500 meters per second. And the fascia is a continuity from those fascial layers to coalesce within the fibrils, within the muscle cells. And forces are usually transmitted by shear stress along the endomysium surrounding the muscle itself. Now, cellular level, the cells respond to extracellular forces. Remember, the interstitial space is kind of held together by the fascia, but the fibers within cells, the actual cytoskeleton, connect to fibers outside of the cells in the extracellular space and interstitium. And then therefore intracellular structures support tension and compression of the fibrous extracellular matrix and the muscle. So it's like this, it's in series, not in parallel, because it goes from intracellular to extracellular space to pericellular to the fascia, and finally the nerve is in control of the whole orchestration. Now, traumatic arthritis of facet joints, here's a nice normal one here. Here's C2 and 3, nice normal hyaline cartilage. The little meniscoid's kind of small here. Here's the collateral ligament. Then during injury, often it can be a compression injury, for instance, in this case, and it compresses the hyaline cartilage and the bone structures together. And this actually produces a macrophages or bone bruise. And on an x-ray, this may have an intact cortex, so you don't see a macro fracture. But on MR, there's marrow edema, so you know it's a bone bruise or trabecular fracture. And it also injures the hyaline cartilage. Now, generally that tears the capsular ligaments, and you have an unstable joint, and post-traumatic arthritis over time, you have literally the bone on bone in your facets, in your spine, in this case, the cervical area. And see how loose and lax the ligaments are. So this is a hypermobile joint that's wearing out, so the cartilage cannot heal. Now, think about the pain generation. Many structures in the neck are richly innervated with C fibers. And we'll talk about A delta fibers as well. Local pressure along the ligament and capsular structures related to stretching mechanically activate these nerves. The nerves can be sensitized over time and excited by naturally occurring inflammatory agents, because with an injury, you might have substance P, pain-producing, phospholipase A, and we talked about glutamic acid. Glutamate is often in these milieu creating pain, and it hits these C fibers, which are unmyelinated. Now, let's talk a second about what difference that makes. These C fibers versus A delta. The group A fibers are myelinated, so they travel very fast. And the larger, thicker they are, the faster that the messages travel along these myelinated fibers. The afferent fibers, the nociceptors, carry information from the peripheral mechanoreceptors, like tip of your finger when you get it burned on a charcoal, to thermal receptors in the dorsal horn of the spinal cord. And that receives that information, transmits that acute pain vertically up to the brain. The group B fibers we'll talk about later. Now, mainly the ones that give us chronic pain, so-called neuropathic pain, are these group C fibers. They're unmyelinated, they have a small diameter, so they have a low conduction velocity. That's important because if you've ever noticed, if you've got any sort of stimulation in the skin surface, for instance, we use a little vibrational device when we're doing injections, because that vibrational input travels so much faster via the group A nerve fibers to the brain, and is so much louder than the little needle sticks that we're doing for, let's say, a needle injection therapy. A lot of times a patient can't feel the injection procedures. So proprioception and those other sensory inputs are so much faster and louder in the brain that a lot of this slow pain message going to the brain is masked or beyond threshold during normal hours. That's why people, when they're walking around, moving around during the day, don't have quite as much pain. When they lay down at night and they're not moving and they don't have any external stimulation from vibration or whatnot, and all they can hear is the pain. So that's basically because you see nerve fibers. Also called the capsaicin fibers, and this is what our glucose therapy treats, and we've talked about that. We will some more. Okay, so the CLC1 is a nice ball and cup relationship here, or convex, concave relation between C0, the occipital condyles, and the superior surface of C1, lateral mass. Then you chop half of that off. Okay, so the posterior ring and the anterior ring of C1, you can see the odontoid of C2. Now you see the convex surface of the shoulder, superior articular surface of C2. And then you see its inferior articular surface is angled in this manner. Now, when you have flexion, you're hitting chin down position. At C0, C1, the occipital condyle will slide to a degree, and you can imagine the tightness of the capsule and how important that is as the flexion occurs. And it puts stress on this concave surface of C1, but it's very stable. And it puts it also puts stress on the anterior aspect of C1, which makes these two footballs slide. And so the lowermost convexity of C1 wants to slide posterior when the head goes forward. It makes perfect sense, not only because of the weight, but also this relationship here. Notice the broadening, the width between the occipital bone and the posterior ring of C1 and the spinous process of C2. See how wide that is in flexion. Now extension, you're looking back to the ceiling. You see the occipital condyle slides forward. And now it's putting pressure along the posterior margin of C2, and these two little footballs react this way. It makes C1 move this direction, and now you get close proximity of the occiput posterior ring of C1 and the spinous process of C2. All right, now here's a case where the patient has arthritic left C1-2 relationship. Again, the biconvex relationship between C1 and 2. And if you look out here at the information, the load bearings here, these meniscoids are very important in this particular joint. And when this joint gets, again, it's the most mobile joint in the body, so C1-2 is moving all the time, 600 to 700 times an hour, even when you're asleep. And these meniscoids get displaced, they can become very painful. Now, let's talk about turning our head right and left. Now, in this case, we're looking at the anterior aspect of the cervical vertebra. Here's C2, the anterior aspect, and the left transverse process of C2. Here's C3, 4, and 5, the anterior surface. C1 is rotated this direction, and if the patient were facing us, he would be looking leftward. And if we could look down the central canal, it would look like this. See how narrow this gets when C1 rotates on C2. So the concept is, here it is in neutral position. See how nice and wide the central canal is when C1 and 2 are appropriately aligned, and it looks like this on a coronal image. When the patient, the rotation at C1 is toward the left, you see how this narrows the canal. If it stays rotated all day, every day, you're going to have trouble with cord compression and a bunch of other things. And we see this a lot post-traumatically when the ligaments are torn and you have malalignment. That's what upper cervical adjustment's all about. Now here's the relationship. Remember we talked about the nice angular relationship here. It creates a nice sturdiness with regards to translation. Either way, the weakness in the craniocervical junction tends to be front and back, or anterior to posterior, less so than lateral. Okay, here is a sublux facet joint. Here's the nice surface view here, and you can see the rotation of the facet, and here's the relationship between the lateral masses of C1 and C2. And then here's the subluxation translation here at C1-2. Again, an arthritic joint here. We saw this slide a moment ago with the meniscoid here and how important that relationship is. Now, when you rotate your head, now this is a posterior view, so it's rotated to the right. This creates compression of the brain stem, just like we talked about a moment ago. So in addition to rotational narrowing of the central canal like this, just from moving side to side, and remember C1-2 is responsible for half of your rotation. So zero, you really can't get to 90 degrees, about 80, 85 maybe. So 40 degrees of your rightward rotation in this particular case is C1-2 alone. The rest of it comes from the facets sliding on one another. So half of your rotation capabilities at this C1-2 level. And when your head's tilted one way or another, it also creates an abnormal configuration of the central canal and compresses the spinal cord. Now this happens to be the dorsal root ganglion up here. The gray matter, remember, here's the ventral horns. And this is the lateral, the posterior and anterior white matter tracts. So the relationship of the cord is opposite that of the brain. Remember, the gray matter is on the cortex of the brain, and the white matter central to the cerebral hemispheres. And then the cerebellum and cord tends to be reversed, where the gray matter is deep and the white matter is circumferential. Now, fun fact, the cause of osteoarthritis is unknown. The fact is, the cause of osteoarthritis is biomechanical dysfunction of the joints. This is ligamentous insufficiency or tightening. And it changes the instantaneous axis of rotation of these vertebrae relative to one another. And again, if you'll notice, when we're in extension, this is thoracic vertebra, when we're looking up, the anterior superior aspect of this thoracic vertebra compared to when you're in flexion looking down travels from B to B1, and then the posterior inferior surface of that thoracic vertebra from extension to flexion goes from A to A1. And if you take the perpendicular bisectors from each of those lines, where it meets is your instantaneous axis of rotation, described by Rouleau. Again, we talked about this in the knee. The importance of having an axis of rotation and maintaining it is how we have the nice Goldilocks relationship. This is the knee. It's easier to talk about because it's the largest joint. A little easier maybe than talking about the facets, but the vertebra have an axis of rotation. It's just usually distant from the segments, maybe a segment or two away. But this is the center of motion, radius of motion for these two vertebral bodies. Now, in the knee, if you go along the posterior cortex of the femur, this is in essence about 5 centimeters off the flat surface of the tibial plateau. This is the motion about the radius about which the tibia travels. So with flexure of the knee, the tibia will travel this way, but it will always maintain its relationship. The flat surface will maintain its relationship to the centroid or central axis of rotation. When the cruciates are torn, that's when you have trouble. And when you do have this relationship, you have the nice optimized amount of vertical compression and translational stress or friction that's healthy for cartilage. You can't have zero and you can't have too much. So when a person's knee hurts and you put them in a knee brace, it may not hurt, but the joint's going to wither. And when they have a torn ligament and they move too much, it's going to wear the cartilage out. Same thing in the facet. When you put a collar on someone, it may not hurt as much, but the absence of motion, the cartilage is going to get sick. So let's look at how cartilage is maintained. Here's the superficial layer here of hyaline cartilage. It's negatively charged when it's healthy, and it's avascular, and that's important. You don't want vessels in the cartilage because when it's compressed, if it had to get its nourishment from an artery or a vein within the weight-bearing surface, it wouldn't get any. It gets most of its nourishment by diffusion from the bone. So here's the calcified cartilage, here's the basal layer, here's the chondrocytes floating around the matrix all the way to the surface. And what allows it to slide is this proteoglycan called Lubricin, nice name, and we'll talk about what that is in a minute. So hyaluronic acid and Lubricin within a joint is more slippery than Teflon. It's awesome, the friction number. Now, and also remember, the collagen is what is really the strength. Humans are about 70% collagen. It's everywhere. In fact, there's 80% as much collagen as a nerve as there is in a ligament. So when you're talking about hyaline cartilage, there's a lot of collagen. Certainly fibrocartilage has a lot of fibrous collagen as well. The biology of Lubricin is to create this frictionless joint motion. It's a surface active mucinous glycoprotein. It's secreted into the synovial fluid, plays an important role in cartilage integrity. So in healthy joints, Lubricin molecules are cohesive to the cartilage surface, and there's a boundary lubrication that presents cell and protein adhesions that you don't want things sticking to your hyaline cartilage. So arthropathy occurring in patients after joint trauma or inflammatory arthritis, or even with congenital lubricin deficiencies, there's an insufficient amount of this slick material, lubricin, and then there becomes damage to the articular cartilage. Lubricin plays a role to prevent this damage, mostly on the superficial zone in preservation of chondrocytes. Remember, we talked about the lubricins right here on the external surface. Now, numerous mechanisms have been posited to explain how articulating cartilage surfaces under load, lubricated by synovial fluid, produce a coefficient of friction. And the mu is an order of 0.01. It's actually less friction than Teflon, which is the slickest stuff that we can make, this man made, which mu is a 0.04. And plus Teflon doesn't doesn't handle load very well. So this is some miraculous physiobiology in joint spaces. Now, hyaluronic acid is the other magic ingredient to Lubricin. It's a natural biomaterial. It's in all healthy joints, particularly facets, but it's depleted in arthritis. So in osteoarthritis, we started injecting hyaluronic acid back in the joint. Well, it doesn't work very well, does it? Most of the Synvisc stuff is made from chickens. It's avian. It's not even our own hyaluronic acid, and it's just viscous, and it wears out in a few months to several weeks to a few months. So all it does is provide slipperiness, but it doesn't provide a scaffolding, and it doesn't react with the lubricin that we talked about in the way that our natural hyaluronic acid works. And so we're using hyaluronic acid from amnion tissues. These are taken from the amnion layer, the placenta at C-section birth, and it's immunoprivileged. And we use it for wound care. We cover wounds with it, but now we've got it to where we can use it in a joint space to provide this hyaluronic acid. Now, the cool thing about amniotic hyaluronic acid, it's a heavy chain. And what that means is when it's in a joint, it'll make the joint quit scarring and it being inflamed and make it start to restore. And that you only have heavy chain hyaluronic acid in little kids from the time they're until they're from 0 to about 2.5 years old. And what that does, it makes macrophages from the M1 type of macrophage, which is what we adults have, that all it knows how to do is to create inflammation and create scar to try to heal stuff. It graduates it from an M1 to an M2 educated macrophage, which doesn't know how to scar. And so by using hyaluronic acid, we can create a milieu in the knee that helps joint lubrication. And if these chondrocytes are abnormal, it makes them undergo apoptosis, organized cell death, so they can make some new healthy chondrocytes. You don't want these senile chondrocytes around. And hyaluronic acid reduces average static and kinetic friction by about 75 to 70%. It's an effective boundary layer lubricant, and that's what we're using to treat osteoarthritis. We've got a new product or two that's about 97% the same DNA as humans. Still an artificial product made by Streptococcus, but now that we've got amnion, heavy chain hyaluronic acid, that's what you put in the knee joint or along the facets, and that helps to stimulate the development of lubricin, which works together to make the joint slippery. Now, once you've torn your cruciate ligament, remember the normal axis of rotation should be along the posterior femur, 5 centimeters off the flat tibia plateau. When that ACL is torn and the tibia moves, this axis of rotation changes. So now it can be, when you put an ACL and it's too tight, it moves this axis of rotation way forward. If it's too loose, it moves it down here and posterior. And all this does is create compression and abnormal range of motion. It wears out the joint a lot faster. So we're not man-made, okay? So it's hard to put the cruciate ligament back, and that's why we're doing stem cell injections into the cruciate to restore it, and that in proper exercise and whatnot, you can restore the axis of rotation. Same thing in facets. Because they are so complicated and their axis of rotation is sort of interesting, you just inject the cell therapies along with upper cervical alignment, then you tend to have these facet articular surface to work well together. Now, here's a normal versus an arthritic joint, just a nice little graphic. Yeah, you see here's a knee, for instance. Here's the femur, here's the tibia, there's a bursa, muscle tendon unit. And again, these are all in series, not parallel. These drawings falsely make us think that they're separate structures. They are almost in a living human or living creature, mammal. They're almost imperceptible, the coalescence between the muscle tendon unit with the underlying capsule, with the underlying synovium. And then as the joint gets maybe injured, osteoarthritis, you start losing your hyaline cartilage because you've lost your ligamentous integrity. And if you've got rheumatoid arthritis, when it's inflammatory arthritis, you got a big joint effusion. And this joint effusion is under so much pressure, it starts to erode the periarticular bone structure. That generally happens in the hand, for instance, in the joints closest to the wrist. And again, here's kinematics of it. What we want, you can see how the knee moves here, the motion and whatnot, and the meniscus or meniscoids, is we want these chondrocytes to be healthy. And for the articular cartilage to be strong and sturdy, you need the chondrocytes, but you need what? Collagen, proteoglycans, triple phase helix. And that's where the Lubricin and the hyaluronic acid comes in. And we're doing those injections now for the facet joints in these folks. Now, As facets start to get arthritic, this is in the lumbar region, but you see large facet effusions here. Here's the central canal. Remember, the facet that's back here posteriorly is from the vertebral body above. Okay, so that's the lower articular facet of, this is at L4-5, this would be at L4, and then here's L5 anteriorly. And on a CT, here's a nice normal facet joint. See the nice normal chondral surface, and then you start to get sclerosis, thickening of the subchondral bone surface, mild narrowing. Then grade 2s, you're going to get narrowing, and now you see fraying and para-articular osteophyte development from hypermobility. Remember, ligament laxity. And then grade 3 is severe narrowing and hypertrophic changes, because it's a lot of weight, and particularly it's up around the cervical spine trying to hold that 12-pound bowling ball up that we call our head. And again, here's the MRI versions of those. Here's a grade 0 normal facet. Here's a grade 1, very mild with a joint effusion, little shallow disc herniation here with the broad-based protrusion type, left pericentral to lateral. Again, T2 weighted, by the way, water weighted here. Water's white. Then grade 2 is sclerosis and narrowing. Then grade 3, you start to get para-articular spurring and see how there's cupping and hypertrophic changes along with facet effusions. Again, on the CT, we're starting to see para-articular facets, and basically that's an instability. And these things are like warm Tootsie Rolls, if you think about it, when they're in motion. So bone spurs can actually be resorbed if you restore the motion. And your body no longer needs that tug lesion for holding up your head. They'll actually resorb the bone spur. Again, here's a nice picture, nice healthy hyaline. This is physiologic loading, meaning nice organized chondrocytes along the surface, and you know the hyaline chondrocytes here, and then underneath is the bone. This is when you have a nice intact capsular ligament, so that just the right amount of compression stress and translational friction to keep the cartilage healthy. If you unload it, you put a neck collar on somebody or a brace on their knee, it might not hurt, but look at how the cartilage is going to get sick. It's Goldilocks. It's got to have just the right amount of compression and translational stress to create a healthy surface. Now, overloading means you got ligament laxity and too much motion, and that wears the cartilage down, so-called bone on bone. So the way that we fix facets and knee joints and whatever that have so-called bone on bone is not to try to plant hyaline cartilage in there like you try to plant a farm, is that we reestablish the integrity of the ligaments. And once the axis of rotation is reestablished, that creates the environment upon which the hyaline cartilage can then resurface. So biology in a normal joint, normal articular cartilage contains no blood vessels. That's a good idea. Blood flow would be repeatedly occluded during weight bearing and exercise, with reactive oxygen species generated during reperfusion. So that's not how cartilage works. It is avascular, and it has specific inhibitors of angiogenesis that maintain this cartilage as avascular tissue. And if you remember, we talked about avulsion type disc herniations that pull the cartilage end plate off. The hyaline cartilage itself is angiogenetic, meaning that that disc will not resorb. You will not form a granulation response to resorb a avulsion type disc herniation because of the angiogenesis inhibition by the cartilage. If, however, you have a non-avulsion type disc herniation, meaning you just have herniated disc, no hyaline cartilage, your body will see that as a foreign body, form a granulation response, and resorb that. But that's based on angiogenesis. So when the hyaline cartilage is in the presence of tissue, it's not going to allow vascular regeneration. The chondrocyte plus normally lives in a hypoxic and acidotic environment. So extracellular fluid values around 7.1 to 7.2, and so therefore it uses a lot of sugar because it's anaerobic. And remember, for every sugar molecule in an aerobic situation, you get 38 energy packets, ATP, adenosine triphosphate. So when you're in a well-oxidized environment, for every glucose molecule, you get 38 ATP. When you're in an anaerobic or hypoxic environment, however, you get 2 ATP. So it's not very efficient. And that's why we use a lot of glucose injection around these folks with arthritis, because the chondrocytes need more glucose to create energy. And remember, 50% of our energy in our body all day, every day is used. All that ATP is 50% of it's going to the sodium potassium pump to pump the sodium and potassium in and out of the cells to allow them to have electrical potential and to allow neural electrical impulses and so forth. So the two sources of nutrients for articular hyaline cartilage are the synovial fluid right there on the surface and the subchondral blood vessels through which nutrients diffuse into the avascular hyaline cartilage. Indirectly, the synovial lining creates a lot of nutritional resources, but the problem is if you have synovitis or inflammation, then you got trouble. Now, intermittent compression serves as a pump mechanism for solid exchange in the cartilage. It's so that if you do joint immobilization, you're going to have degenerative change, just like if you keep a disc and it doesn't, if a disc cannot move, it'll get sick. And that's why static or rigid discs get sick faster than hypermobile disc and are often more painful. So exercise increases the solute penetration in the cartilage. And so during weight bearing, fluid escapes from the load bearing region to flow to other areas. So this back and forth movement, that's why it's so important to do rehab in addition to creating the structural alignment at the craniocervical junction. But you can't just keep them still. You got to let them move, but they got to move in appropriate fashion. So the rehab is very particular. And if they move and become out of line again because the ligaments are torn, then we add cell therapy to that. So now you do alignment, see how they do, try to get them to rehab. Oops, they're malaligned. So let's do some injection around the cruciform and axillary ligaments, accessory ligaments, restabilize that relationship with C1-2, then they can do the rehab. Deeper layers of cartilage are vascularized, and again, that's the surface layer hyaline cartilage is very avascular. And again, inside of these arthritic joints, it's basically a forest fire. So when we first see a person with hot facets or inflamed joints, we don't put glucose, we don't put cell therapy, stem cells, or any sort of cell therapy in the joint because it just melts. We use glucose therapy initially. And glucose tends to be restorative, and it's an insulator as opposed to putting salt in there, which is a prolotherapy. But salt stimulates the production of electrical impulses. So you don't want to put salt in a joint space. Sugar is an insulator, and salt is an accelerator. But some people do use salt as a prolotherapy. Not me, though. That's a little painful for me. So the synovium talks about how that works. Within the synovium, you have synoviocytes. Well, they're macrophages, okay? And some of them, the type A's are macrophages, so they engulf trash and sort of things. And the type B's are fibroblasts, so they're creating collagen after the type A's resorb and melt down the bad scar or collagen. The type B's produce new collagen as a fibroblast. And then they have adhesion molecules and so forth. And then this is when the cells of the lining layer of the synovium are the major components of synovial fluid, and that's where lubricin and hyaluronic acid comes from. So lubricin attracts an additional layer of water molecules on the edges of the articular cartilage and smooths the movement between the opposing surfaces. Hyaluronic acid, or hyaluron, HA, protects the synovium from being locked and pinched in between the cartilage. And again, here's the layers of a joint and how it forms from blastema to cartilage to mesenchyme. I'm going to let this be read. There are fat pads. that are involved in inflammation of joint disease. Remember how highly innervated they are, so they can be generators. And fat pads, particularly on the knee, can be trapped, and this compression can be pain producing, while also facet joints in the neck, when they're loose, can trap the meniscoid tissue and pinch it. And that's why they have to be reset and realigned. Okay, joint innervation. Each joint has a dual nerve supply. Independent branches of the adjacent peripheral nerves and articular branches arise from the related muscle nerves. If you remember, John Hilton in 1863 stated that all joints are controlled by their innervation. In other words, the nerve overlying a facet joint, for instance, is in control not only of all the bone, cartilage, and collagen and ligament structure that comprise the joint, it's also responsible for the overlying skin and then the interstitial space. So what we realize now is we don't need to replace a joint, we need to restore the nerve. And it, in turn, will allow the joint to start moving normally and restore itself. And that's why alignment at the craniocervical junction and anywhere along the upper cervical spine is so important and dependent on innervation and proprioception and vibratory sense and so forth. And so we start melting these nerves with radiofrequency ablation. That's not taking care of the problem. That's sweeping it under the carpet. It's going to come back when that nerve's restored. Or putting steroids in there, which are crystalline, and they create little small infarctions. So we're learning from that. Again, normal joints have an afferent sensory branch sending information to the spinal cord. And when the spinal cord figures out, it sends it to the brain, and the brain decides what to do. It sends it down an efferent motor innervation to allow the joint to move. And again, we talked about the fast conducting, thick myelinated A fibers. And then we talked about the slow conducting unmyelinated C fibers that transmit pain. These are the ones we want to treat with our glucose therapies because they're neuropathic in nature. The fast conductings tend to be more immediate pain and heat and chemical toxicity for acute problems. And these unmyelinated slower C fibers transmit chronic neuropathic pain. And those are the ones that we're treating with our glucose injections. Normal synovium is ritually innervated by the unmyelinated nerve fibers, and then they can follow the course of the blood vessels so that they create a neurovascular bundle into the synovial lining. These nerve fibers do not have specialized endings and therefore are slow conducting fibers, and they transmit the diffuse, burning, aching pain sensation, so-called neuropathic pain. And that's a lot of what we see for people with migraine headaches. A lot of that happens right there at the lesser and occipital nerve sites and L3 and skull base and along the facets. Sympathetic fibers are an entirely different group, and we'll talk in a little bit about them. The neuropeptides that create trouble are substance P, pain substance. The calcitonin G related peptides, CGPR or CGRP, receptors are all over the body, and they are little culprits who are in the central nervous system as well as the peripheral system. And as it states, calcitonin gene related, they're protein based and calcium dependent. There's neuropeptide Y, and there's VIP or vasoactive intestinal peptide. These are all neuropeptides that we see that are out of balance, particularly in trigger points. If you can take the fluid out of a nodular trigger point along the trapezius muscle, this is what's going to come out of that. Okay, so afferent nerves, we'll move on. And you can go back and freeze frame this and read these. Neck pain has an annual prevalence of 30%. Very common pain syndrome. Half the patients proceeding to chronic pain, and that's what we want to do is take care of this. We don't want to take non-steroidal anti-inflammatories like ibuprofen and Motrin and such, and we don't want to take narcotics for sure. But if we know if 1/3 of us have neck pain and half of us are going to have chronic problems down the road, we need to fix that. And a lot of this is cervical facet joint pain or craniocervical junction malalignment. We can fix that, and the sooner the better, frankly. And no scientific evidence that steroids provide long-term pain relief. And this idea of neurotomy or radiofrequency ablation of the facet joints to disrupt the nerve supply is also falling out of favor. So spondylosis means just arthritic facet joints, and there's a dysfunctional stage where maybe initial injury and you sort of have abnormal motion and kinematics, and eventually the ligament laxity creates an instability or unstable stage. And then finally there's a stabilization where you actually have fusion, autofusion of these hypermobile facet joints. And they're so-called zygapophyseal joints. The cervical facet joints have specific referral patterns, and they can masquerade as different sort of neuropathies, but in fact, these pain patterns are produced by a specific facet. C23 is in this particular shaded area here. So about somewhat less than half of chronic pain is actually from the facet joints. An acute injury usually starts the problem, and then rotational injuries and so forth, and it has these referral patterns. The patient is unable to move their head and neck normally, and they're often head forward posture. We've talked about cell phone, iPhone, head forward posture. You realign C12, maybe it doesn't stay aligned, and so then therefore we start. You can do local anesthetic just to make sure that when you inject it in a certain area, the patient, oh, my pain's gone, it's just going to come back. But if you put glucose in there, glucose is an analgesic. Lidocaine's an anesthetic, meaning if you have a sore shoulder and I inject it with lidocaine, it won't hurt, but you won't have a shoulder. You'll have no motor, sensory, or pain. That's anesthetic. If you put glucose in it, it's a analgesic, meaning no pain, but you still have motor, sensory. So that's why we like to use glucose, particularly on the neck and spine, instead of these lidocaine injections. Again, this just tells you what's going on in a facet joint and how hot that is. And here's the dorsal root ganglion, and the medial bundle branch is here. So you see all this innervation. So we like to just bathe this with glucose, not steroids, and don't melt it. Again, there's your referral pattern. And facet arthropathy, an inflammatory component, you'll have juicy facets and you'll see fluid in the facet joints. This is a T2 weighted image. Notice the atrophy of the multifidus group. Generally, this is fat atrophy. No, again, here's the erector spinae musculature, too much fat or marbling here. Here's the psoas muscle there, so-called the fillet. I guess if you cut that in half, and this was a porterhouse steak, there's your fillet and here's your neck strip. But notice how the facet fusion is creating a capsular cyst. It's intruding into the central canal. So the inflammatory arthropathies in the joints can create trouble just beyond just the facet joint. They create mass effect from these darn decompressive cysts, much like a Baker cyst in the knee or popliteal cyst in the knee with large knee effusion. It's just a decompression chamber. And then the degenerative arthritis, just hypertrophic changes. Look at the marrow, how the fatty marrow signal has changed. Now let's talk about facet joint injections. Here's our targets. We're really trying to bathe the sensory nerves that are creating this chronic neuropathic pain. And we may use a little higher concentration of glucose. D5, 5% glucose is iso-osmolar, and nerves love that. It's isotonic. But if we want to tighten the ligaments like prolotherapy, proliferative therapy, we might inject 12.5 to 25% glucose. And that creates an inflammation that tightens the ligaments. That may be so deeply, we might inject higher concentration of prolo for prolotherapy and tightening of the ligaments, which is the problem, right? Ligament, ligament, ligament. And then maybe more superficially, we'll do dextrose, the 5%, and it turns off these little pain fibers. And all they're yelling about is that there's low glucose in an area, glycopenia, it's called. Again, here's your facet joint referral patterns. So the integrin cytoskeleton and mechanoreceptors stimulate catabolic pathways. This is within the cell. So even though you think about our skin surface, underneath that, is the interstitial space, and then you go through the muscle into the periosteum of the bone and the collagen around the ligament structures, and you keep going deep, 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 deep. Eventually, you're intracellular. So the cytoskeleton, or the microtubules of each cell, is its skeletal structure. And to maintain cell health, it's got to be able to move. And a lot of times when we inject these hypertonic fluids around the cell, like glucose, it'll pull fluid out of the cell and make the cell change shape. That's essentially doing microscopic push-ups. It's very healthy. Cells need to move to be healthy. So the integrin cytoskeleton and the ion stretch mechanoreceptors stimulate these catabolic pathways. They produce matrix metalloproteinases. Well, these dissolve scars. This is also, MMPs are all over the body. And when they're released by an injury, they show up and dissolve the scar and allow you to break down cartilage in the extracellular matrix. So there's articular cartilage breakdown, but what you eventually want to do is to change the extracellular matrix to make new cartilage. So when cartilage is sick, it's supposed to break down, undergo apoptosis, it's called, programmed cell death. When it doesn't do that, you've got an old cartilage cell, and it's kind of in the way, and then the joint entirely is sick. It's just a micro environment, the whole intra-articular environment. Again, here's the injection sites if you want to do facet injections. Usually these are done fluoroscopically under x-ray guidance here. We put a needle in here. You can put it in a facet joint if you want. I've had just as much luck not sticking a needle in a hot joint. It's really not helpful. We already said it's acidotic in there, so being hypoxic, it's like the surface of Mars. So why do you want to put cells in there? They won't live. Put restorative solutions around it, and maybe tighten the capsules a little with some higher concentration glucose. But we got to get C1-2 aligned, or none of this stuff will realign or stay aligned. Now the FDA is warning about epidural steroid injections. They're going to stop this. There's no literature to support it. It's just been a revenue stream for some of these pain doctors. But once they stop paying for it, I guarantee you they'll stop. So we can do intra-articular injections. If you don't think you really need to do that necessarily. The medial bundle branch blocks, where you melt the nerve with RF, you just need to stop doing that. And again, here's the sites that you can inject on when you're trying to catch the medial bundle branch, and then the collateral ligament complex around the facet joint, and then the little bundle branch. So through one little stick in the skin surface, you can angle the needle upward, and you're going to get this red dot here. So you get the medial bundle branch from that C4, and then you pull the needle back to about right here, but not all the way out. Redirect it, go straight in, and now you're maybe into it, but certainly along the facet joint. Retract the needle again, but not all the way out of the skin, and redirect it caudally, and now you're going to hit that medial bundle branch. So by making one hole in their spacesuit, one hole of the skin, you can actually get 3 or multiple injection sites without a whole bunch of breaking the skin surface. Now, here's why this is important. People just tell you, remember this drawing, you go, well, how could all this facet be creating all this trouble? Look at the innervation, how richly that's innervated. Here's the medial bundle branch, but we're doing a lot more than that. We put steroids in here and melt it. Look at all the stuff we're melting. We got to stop that. Put restorative solution in there, align C1-2, and do proper rehab. Okay, so again, here's the injection sites that we use. And talking about facet joint innervation, medial bundle branch here. And it also innervates the multifidus, so that when you melt these, or if these are compressed or diseased, that's why the multifidus gets atrophic, see, because it's innervated by this dorsal root branch. Again, the extensive innervation of the spine. So if we're going to do deeper injections, here's the midline, the patient face down. Here's posterior ring of C1. Here's the spinous process of C7. And you put a dot at each spinous process. So there's a midline, 1 finger breadth off, and you take a needle and angle it at about 15 degrees and go down, you'll land on the lamina. And you can inject, and not steroids, but we like to inject glucose along this for prolotherapy. Maybe a little higher concentration, tighten the posterior capsule and so forth. Then you go 2 finger breadths off midline. So here's 1 finger breadth, 2 finger breadths off. And at 45-degree angulation, you can hit the facet joint. Here's a pencil it's horizontal, and then here's the needle vertical. So that's 90 degrees. So halfway is 45, and you go straight down, you're right on the facet. And the beauty of these posterior injections, they're very safe because most of the stuff that you don't want to hit with a needle is around front. So you got like the vertebral artery is hidden by the transverse processes, and you got all the sympathetic system, mostly that's around the front. So these posterior injections are very safe. Now here's C1-2, the atlanto-occipital joint. And again, the convex concave relationship. Again, just here's the C1-2 relationship here. That was the CO-C1, by the way. The C1-2 is 2 footballs, 2 biconvex relationship. And with those little meniscoids. And you can see, here's a midline cut here, proton density, sagittal view. You can see a low-lying cerebellar vermis, carry 0. Slight posterior inclination of the odontoid, so you got some narrowing here. And then you loss of curvature right here. So that creates an elongation of the cervical spine. Notice how the spinal cord seems to go out of the field of view. That's because there's scoliosis. It's moving rightward so that this midline cut catches the cord, but all of a sudden the cord's gone. Where'd it go? It's related to a dextroconvex scoliosis. Now, if you go farther right, you'll see the sclerotic facet joint. See how the end plates are sclerotic, and look at the vertebral arteries here. Then that's to the right side, now you go to the left side. And again, you're seeing hypertrophic changes in sclerosis. And again, here's the left vertebral artery, smaller in this particular patient. So here's an asymmetric hypertrophic facet in a coronal plane. And here is in sagittal plane. Notice the dilation of these posterior retrovertebral venous outflow tracts. We talked about those. When those are dilated, by the way, these 3 images are from a recumbent patient. So when the patient's recumbent, these should be small. Remember, when you're laying down, the venous outflow goes to sagittal sinus, transverse sinus, sigmoid sinus, jugular vein. And then when you stand up, take a deep breath, the increase in thoracic pressure slows the jugular venous flow, and now most of your venous flow in an upright patient goes through these potential channels, perivertebral artery, and then the internal and external posterior vertebral artery encephalic veins. When you wear a neck tie like this, we've done studies, it compresses the jugular vein, which creates indirectly increased intracranial pressure because the encephalic outflows is compressed somewhat. And it creates a lower cerebral blood flow to people that wear ties. Isn't that interesting? I wear them anyway. I'm not getting dizzy. I'll let you know. And cervical spondylosis, instability connection, we just talked about. Hypermobile ligaments create an ankylosis or stiffening and hypertrophic changes of the spinal axis. At some point in time, you can have so much osseous hypertrophy of the facets and the uncinate processes and the ligamenta flava that you might have to have surgical decompression. But here's a nice normal central canal, but it's tight on this side, compressing the cord. If you're getting leg weakness, muscle atrophy, then you need surgical decompression because of the 3 symptoms that you have from spine problems: pain, sensory, pain, and motor. The sensory fibers require the most oxygen. So when you get a compressed nerve, the first thing you're going to get is numbness. But that doesn't mean that you have to have surgery, because you still have pain and motor function. The second thing, and a compressed nerve requires the most oxygen, not quite as much as sensory fiber, but the pain fibers do. And also they require glucose. So the second thing you get is after numbness, you'll get pain. But hey, your muscles are okay, no atrophy. But when the entire nerve is being compressed or the cord is compressed as in central stenosis, you start to get atrophy. When you get motor signs, you need to have surgical decompression or some form of decompression. Okay, now let's talk about the ligaments. Again, the best teachers are those who show you where to look, but don't tell you what to see. So I'm going to try to show you what to look at, sort of the anatomy as we know it today. Realize this stuff changes. There are ligaments to be named later, literally, in the cervical regions, posterior craniocervical junction. So this is an ongoing learning experience, but we do know that there are basic ligamentous structures, and we're going to go through those. This is kind of how some people look at the ligament structure. And unless you're Oriental, this is Chinese arithmetic. What we now know is that you have a posterior longitudinal ligament that transitions at about the base of the odontoid process. The same structure is now named the tectorial membrane vertically, and it coalesces with the clivus, the periosteum here. Remember, everything's in series, not in parallel. So the innermost layer, the dura, is this surface layer, and then the tectorial membrane is here until about there. And then when it's inherent to the posterior cortex of C2, this is the posterior longitudinal ligament. Notice how the PLL is attached to the outermost annulus of C2-3. Again, these structures are in series. So the dura, posterior longitudinal ligament, outermost annulus, tectorial membrane are almost inseparable, although you see a potential space. Then they get up here to the cruciform ligament. And the vertical and caudal bands of the cruciform ligament are creating this anatomy. Apical ligament here, and then a potential space with some fat and some neurovascular structures here at the tip of the odontoid. And then you have, here's the atlas, and here's the occiput. So you got the anterior atlanto-occipital membrane. And here's the anterior atlanto-axial membrane. And you keep going south, it's the anterior longitudinal ligament. Kind of coalescent, although we give it different names, it's basically the same. And again, the ligaments are coalescent with the outermost annulus, which is contiguous with the concentric rings of the annulus fibrosus here. Now, if you go posterior, here's the atlas here. So posterior atlanto-occipital membrane, PAOM is the structure. And there's a hole here. What's coming through here? This is where the V3 segment becomes the V4 segment of the vertebral artery when it passes through the dura. And here's C1, the suboccipital nerve. C1's coming right through with the vertebral artery. And then here's the posterior atlanto-axial ligament here. Now, Ron Tribble is our medical illustration. It's beautiful three-dimensional relief of that same anatomy. And again, here's the dura mater is removed on this one. So this layer will be the posterior longitudinal ligament adherent to the outermost annulus that goes to about this level, very tightly bound to the periosteum of the posterior cortex of C2. Then there's a little potential space. Well, it's still the posterior longitudinal ligament, but for some reason, it is now termed tectorial membrane, which underestimates it. It's just a membrane. It is one tight little structure. And it also, when you cut them in a cadaver, the flexion check is gone. So it's extremely important in maintaining normal amounts of flexion, the tectorial membrane. And again, you can see the cruciform ligament here. Here's the little synovial capsule, the posterior atlanto dental joint, and here's the anterior atlantodental synovial joint. And here's the apical ligament here. And then again, the anterior atlanto-occipital membrane, atlantoaxial, and anterior longitudinal ligament here. Now in the back, another structure we didn't comment on before, this is the myodural bridge from the capitis rectus minor muscle to coalesce into the posterior atlanto-occipital membrane, which is contiguous with the dura. And when that's torn, you got trouble. And the myodural bridge, like as we talked about, was the first structure that was realized that the MSK system had a direct connection to the central nervous system. And that's in the 1999 Grant's Atlas. Now, here are several MRI sequences. This is T1 sequence here, proton density here, and T2, the far right pair. So the fat density, T1 is fat related, but it's a short echo time. So we can see a torn ligament here. Sometimes though, on fat weighted, the CSF, there's not enough contrast here. You can't see the ligament from the cerebrospinal fluid. That's why we do proton density, which makes the cerebrospinal fluid bright enough. You can see the obvious tear in the tectorial membrane here. And if you go on to T2 weighted, look how normal it looks, and that's because an artifact, when you tear a ligament, there's heme released or bleeding, and heme creates a susceptibility artifact. So we can't use T2 imaging to find these ligament tears. We need to use the proton density. Now, all three of these along the bottom are 1.5 Tesla images, and they now have 3 Tesla. Some places actually have 7. I wouldn't recommend getting in that unless you know what you're doing. But the point is 1.5 Tesla is considered imperative to do these images. You don't need that. These are 0.6 Tesla. These are off the upright MR system, and you have very strong surface coil. So it's not about the base strength of the magnet or B sub 0, which is 0.6 Tesla. Even with a 1.5 Tesla magnet, over twice as strong, because the surface coil technology, we can see the same spatial resolution. And here's your proton density showing the ligament tear. You can see it on the T1 weighted in proton density. Again, you get to T2, artificially normal. And because of the hemorrhage, when you tear the ligament, it stays behind forever. That iron stays in the tissues. From the posterior aspect, the external craniocervical ligaments, look at the facet, capsular ligament structures here. You know that this is a look at the patient from the anterior here. So there's the anterior longitudinal ligament. You flip it around and look from the posterior. Here's your posterior atlanto-occipital membrane here. And remember how the V2 segment of the vertebral artery comes up through the foramen transversalis of C2. And from there on through C1 until it pierces the dura, that's the V3 segment of the vertebral artery. And it pierces the dura right here. And remember, the calcification of that arcuate ligament creates a so-called ponticulus posticus, or a bone roof to this canal, which predisposes those patients to vertebral injury and chronic issues, vertebral basilar insufficiency. Now, when you tilt your head to the right, this is from a posterior view, let's just pretend, this C0 portion, the occipital condyle is going to slide this way, and then the occipital condyle on the left slides up and out, and here's the superior shoulder of C1. This is going to compress C1 to push this way, because can you see how the wedge relationship here with stress out here is going to make this lateral mass move to the midline? So it's going to narrow that atlantodental interval on the left side and widen it on the right side as the C1's push this direction. And that's when you rotate the patient's ear to the right, or right head down position. Now, if you look at the ligaments underneath and think what's going on, the occipit's sliding that way. So here's a nice normal relationship when the occipit's going this way. This bone is getting lax, and this one's getting lax here. This is the reverse of this view here. So that when this occipit is sliding downward, it's taking stress off of that alar ligament, making it lax and making it tight here. So when your left ear is going down, you're tightening the ligament here and loosening the alar on this side. But because of what you're doing to C1 is actually pushing C1 this way and tightening that ligament, loosening that ligament. This is the transverse band of the cruciform ligament. Here they are in normal relationship in a neutral position. That's left head bending, and this is right. Now, again, this wedge-like relationship of C1 is kind of exaggerated, but you get the idea of how stable this is. The instability is way more in an anterior-posterior relationship because of these shallow relationships versus these very deep angulated relationships. So the occipital-atlantal joints on the lateral view, on the left, on the AP view on the right, the plane of articulation is less in the sagittal plane than in the frontal plane. So traumatic anterior-posterior occipital subluxation is more likely than lateral displacement for this very reason. It's just a way more stable relationship. So you don't see lateral displacement so much as you do anterior-posterior. Again, here's another look at the flexion here, and it creates pressure on the front of C1, pushing it back, because remember the biconvex relationship here. So when you tuck your head down, C1 translates posteriorly. When you look up at the sky, this pressure back here pushes C1 anteriorly. And again, we talked about this is a much more unstable relationship in the sagittal plane than it is in the coronal plane. So again, just showing that another way. When you're doing flexion here, you're putting the weight over the central or mid body of C1, and you're pushing him down this way. Here's a neutral view. Whereas when you're looking at the ceiling, you're pushing the weight here, it pushes it that way with flexion and extension respectively. Now, if you look down the central canal, look at the width of that. These are anatomic coordinates from dead center, so dead center to the to anterior to leftward and so forth. So it's going to change height of C1 relative to C2, and in this particular case, we're going to see narrowing of the central canal. When you look all the way to the right, you're going to narrow the canal this way. And as you start to look back toward midline, here's nice neutral position. Then when you start to look left and rotate C1, see how it narrows the central canal. Goes in this way to that. And again, when you're looking from left to right, this is narrowing the central canal. It could potentially compress the spinal cord if it's left that way for long periods of time. Now, again, when you rotate here's the nose, rotate the nose to the right, half of the rotation from neutral staring straight ahead to the far right rotation, half of that motion occurs at C1 too. And the other half is the sliding of the facets down here that slide like roofing shingles. And when you're doing that, sliding C1, you can see how it changes height from neutral, the tallest, to getting shorter, whether you're looking rightward or leftward. This is the relationship here between C1 and 2. Again, here's the vertebral artery. We got to be cognizant all the time. The V1 segment, or preforaminal, goes from the subclavian artery on that side past C7. C7 doesn't have an opening for it, although it actually does. It just doesn't go through it. Probably naturally selected because it just would be another place to transect the vertebral artery in a caveman. So those that didn't have that, and it was only tethered at these numbers of levels, probably tended to live longer and have more offspring, the Darwinian theory. So the V2 goes from the transverse process of C6 to the transverse process of C2. And then the V3 segment goes from C2 through C1 over the ridge there, or the posterior ring of C1, to enter the dura. Once it pierces the dura, it becomes a V4 segment and joins its little friend from the other side to form the basilar artery. Again, the only place in the human body where two arteries come together to form one. And this person's looking to the right, and it stretches the V3 segment. So patients that have a dominant left vertebral artery, for instance, have a hard time looking to the right because it cuts off flow to the contralateral left vertebral artery. So if you got a left vert dominant system and you cut the flow off looking to the right, you'll have syncopal attacks. Whereas if you got a big fat left vertebral artery and a small right, when you look to your left, you kink off the small right one, but you're used to not having much flow there, and you don't compromise your major garden hose. All right, and so impact of distorted axis on the foramen magnum and body structure. Here's a normal foramen magnum here down the center again, and here it is with rotation or malalignment. You see what we're doing to the central axis here. And also you notice when C12 is malaligned, as you know, the rest of the body compensates all the way to the ground. So alar ligaments are a little tricky to assess. I think what we'll do is let's stop at this level because this is an important concept. We'll pick this up in the next lecture series. We'll start mid-ligaments.